Hello everybody. We'll talk today about endocrine pathology and pregnancy. I'm Dosent Əliyeva, Associated Professor of OBGYN Department of Azerbaijan Medical University. The endocrine disease is common in pregnancy, and most pre-existing endocrine conditions, if well controlled, have little impact on maternal or fetal morbidity. But uncontrolled endocrine conditions in pregnancy are associated with a variety of adverse fetal outcomes and maternal morbidity. Also, I have to mention that the transplacental transfer of maternal antibodies can have adverse fetal or neonatal consequences. The initial diagnosis of many conditions is hindered by the overlap of symptoms that occur in normal pregnancy and those that suggest specific endocrine pathologies, and also by the change in reference range for common biochemical measurement that occur as a result of physiological changes in pregnancy. The extensive hormonal adaptations that are necessary in pregnancy occur as a result of interaction between fetal-placental unit and the maternal endocrine system. These adaptations are extensive and are crucial for pregnancy, delivery, and the breastfeeding to occur successfully. I have to tell that almost every endocrine axis is altered in pregnancy. Diabetes mellitus and thyroid disease are relatively common in pregnancy. Most other endocrine disorders are either very rare or they are associated with impaired fertility, and therefore they occur rarely in parturients. The gestational and pregestational diabetes make up the most common maternal metabolic disorder of pregnancy, and suboptimal control of blood glucose has the potential for serious maternal and neonatal adverse effects. Three types of diabetes affect pregnancy: gestational diabetes mellitus, type 2 and type 1 diabetes mellitus. The latter two are referred to as pregestational diabetes because the onset predates the current pregnancy. So, the gestational diabetes mellitus is any degree of glucose intolerance with onset or first recognition during pregnancy, and this accounts for 90% of cases of diabetes in pregnancy. And the pregestational diabetes, which includes type 2 and type 1 diabetes mellitus, I have to tell that the pre-existing type 2 diabetes accounts for 8% of such cases, and just 1-2% account type 1 diabetes. According to WHO classification, the type 1 diabetes is characterized by autoimmune destruction of beta cells of the pancreas. Type 2 diabetes is characterized by insulin resistance and relative insulin insufficiency. The gestational diabetes mellitus, which is carbohydrate intolerance, identified during pregnancy and is also characterized by insulin resistance and relative insulin insufficiency, as we mentioned before. There are some rare types of diabetes, such as drug-induced diabetes or abnormalities of beta cell function. Gestational diabetes mellitus and type 2 are generally considered to be the same disease, just manifesting at the different times in life. The pregnancy is believed to unmask the tendency toward type 2. The 5-year risk of developing type 2 diabetes in women with gestational diabetes is as high as 60%. The prevalence of diabetes in pregnancy has increased substantially over the last 20 years because of the obesity epidemic and improved diabetes mellitus screening. A woman's risk of developing gestational diabetes increases from as low as 4% in underweight to greater than 15% in obese women. And diabetes mellitus complicates between 6 to 7% of pregnancies. Gestational diabetes accounts for approximately 90% of these cases. The infants of mothers with pre-existing diabetes mellitus experience twofold the risk of serious injury at birth, and these injuries are associated with shoulder dystocia. We will talk about that. They experience threefold the likelihood of cesarean section and fourfold the incidence of newborn intensive care unit admission. Okay, let's see what's the physiology of maternal fetal metabolism in normal pregnancy. In the pregnant woman, each meal sets in motion a complex series of hormonal actions, including a rise in blood glucose and the secondary secretion of pancreatic insulin, glucagon, somatomedins, and adrenal catecholamines. All women have a 50–60% decline in insulin sensitivity as the pregnancy progresses. The tendency to develop hypoglycemia is present. When we talk about hypoglycemia, we mean plasma glucose mean 65–75 mg per deciliter. And this hypoglycemia occurs between meals and during sleep. Why it happens? It happens because the fetus continues to draw glucose across the placenta from the maternal bloodstream, even during periods of fasting. And intraprandial hypoglycemia becomes increasingly marked as pregnancy progresses and the glucose demand of the fetus increases. By the third trimester, 24-hour mean insulin levels are 50% higher than in the non-pregnant state. The placental hormones are involved in the glucose metabolism. And what type of placental hormones are implicated in the development of insulin resistance? On the first place is progesterone, which is known to enhance insulin release from the pancreas. The cortisol increases during pregnancy to threefold the non-pregnant value. High cortisol increases insulin resistance in the skeletal muscles and increases hepatic glucose production. Leptin is well-known hormone of appetite, increases during second and third trimester and plays a role in satiety and obesity. And of course, it's elevated in women with gestational diabetes. Adiponectin, it is a protein made in adipocytes. Its low levels are associated with gestational diabetes and type 2 diabetes. The next one is human placental growth hormone, which is similar to human growth hormone, and this hormone increases up to 8-fold during pregnancy and is shown to cause severe insulin resistance. Next hormone is human placental lactogen. It rises almost 10-fold during pregnancy and stimulates the release of fatty acids and lipids from fat cells. It is elevated when blood glucose is low and decreased when blood glucose is high. And this hormone causes the pancreas to release insulin. The last one is tumor necrotizing factor. It is a cytokine and induces insulin resistance. Okay, so what happens with the pathophysiology of maternal fetal metabolism in diabetes? If the maternal pancreatic insulin response is inadequate, maternal and then fetal hyperglycemia results, and this typically manifests as recurrent postprandial, that means after meal, hyperglycemic episodes. These episodes are the most significant source of the accelerated growth exhibited by the fetus, and surging levels of maternal and fetal glucose are accompanied by episodic fetal hyperinsulinemia, and this fetal hyperinsulinemia promotes excess nutrient storage and it results in macrosomia. The energy expenditure, which is associated with the conversion of excess glucose into fat, causes depletion in fetal oxygen levels. And this episode of fetal hypoxia, they are accompanied by surge in adrenal catecholamines. What are functions of these adrenal catecholamines? They cause hypertension, cardiac remodeling, and hypertrophy. Besides, they stimulate of erythropoietin, red cell hyperplasia, and increased hematocrit. Polycythemia, which is when the hematocrit is greater than 65%, it occurs in 5–10% of newborns of diabetic mothers. The high levels of hematocrit in the neonate lead to vascular sludging, poor circulation, and as a result, postnatal hyperbilirubinemia. I would like to mention the Pedersen's theory about the hyperinsulinemia and macrosomia, so-called the Pedersen hypothesis. In the 1980s, Frankel from Northwestern University presented a lecture theorizing that alteration in metabolic states could function as a teratogen. Please do not forget about that. And recent studies have focused on pregnancy as a critical period during which the developing fetus is programmed with an increased risk for non-communicable diseases such as obesity, diabetes, heart disease, hypertension, and so on. What is diabetic embryopathy? The high concentrations of glucose are known teratogen. It's well known now. Diabetes-related anomalies occurs in all organs and systems. The most commonly affected systems are the heart, the genitourinary tract, the craniofacial, and the brain and spine. Uncontrolled blood glucose during the first 8 weeks, which are considered organogenesis period of pregnancy, is the concerning period. The risk of an anomaly increases linearly with the amount of maternal hyperglycemia during this crucial time. So, what systems are affected? The pathology of the heart, hypoplastic heart, atrial septal defect, ventricular septal defect, double outlet transposition, tetralogy of Fallot. The next is brain and spine, anencephaly, holoprosencephaly, encephalocele, hydrocephaly, microcephaly, spina bifida, and coarctation. In genitourinary tract, renal agenesis is common. Craniofacial pathology, cleft lip, cleft palate, microtia, eye defects, micrognathia, skeletal systems, syringomyelia, sacral agenesis, vertebral defects, and lip defects. Besides, there is a risk of respiratory distress syndrome, macrosomia, and other pathologies. What are the neonatal complications of diabetes? The first one is neonatal hypoglycemia, when the blood glucose level is less than 40 microgram per deciliter in the first 12 hours of life. The next one is neonatal hypoglycemia, when an ionized calcium is less than 4 milligram deciliter or total serum calcium is less than 7 milligram per deciliter. I have to mention that most neonates are asymptomatic and the condition resolves without treatment. Screening for hypoglycemia is recommended only when symptoms such as lethargy, apnea, seizures, or jitteriness are present. Neonatal hyperbilirubinemia or neonatal jaundice is caused by the breakdown of the fetal hemoglobin, which the neonatal liver is unable to manage efficiently. The next one is shoulder dystocia, which is defined as delivery of the fetal head with impedance of delivery of the fetal shoulders. When birth weight is greater than 4,000 grams per kilogram, the risk of shoulder dystocia is between 9.2 and 24%. The birth weight is greater than 4.5 kilogram, the risk increases up to 50%. And the consequences of the shoulder dystocia include clavicular fracture and brachial plexus injury. And eventually the last complication is of course stillbirth. So, what is the target blood glucose and glycohemoglobin or glucosylized hemoglobin A1C? The risk for congenital malformations varies with maternal glycohemoglobin level. Women with optimal glucose control and glucosylized hemoglobin of 5–6% have fetal malformations rate which is similar to those of general population, which means 2–3%. So, the glycohemoglobin should be below 6.5%. Please remember this 6.5%. This level has been shown to reduce the risk of congenital anomalies. Women with poor glucose control and HbA1c levels in excess of 10% have a between 10–25% risk of having a fetus with congenital malformations. For women with type 1 or type 2 diabetes mellitus, the focus is achieving a glycosylized hemoglobin level less than 7% to reduce the risk of congenital abnormalities. So, preconceptionally, a fasted blood glucose between 80 and 110 mg per deciliter and a 2-hour postprandial blood glucose of less than 155 mg deciliter is the goal. These levels will achieve a glycohemoglobin less than 6.5%. Okay, now let's talk about type 1 diabetes, which is caused by autoimmune destruction of the beta cells of the pancreas. It's well known. The diabetic ketoacidosis, the patients with this type diabetes, type 1 diabetes, they experience a lower threshold for the diabetic ketoacidosis. The morning sickness, which is considered normal for pregnancy, it can exacerbate anorexia. And during episodes of DKA, there is a significant risk of fetal death. The renal disease, women with chronic hypertension or impaired kidney function may experience worsening of disease during pregnancy, because as you know, the diabetes 1 affects small vessels. The next is again associated with this problem, retinopathy and the cardiovascular disease. There is an increased risk of macro and microvascular disease. Hypertensive disorders of pregnancy, the risk of preeclampsia and gestational hypertension is increased between 3 to 4-fold. And up to 15% of all pregnancies are complicated by diabetes in total. Less than 1% of those patients will have type 1 diabetes. And the onset of the type 1 diabetes is usually during childhood, it's well known, and there is a peak in diagnosis between 5 and 7 years of age and near puberty. Greater than 85% of diabetes in persons younger than 20 years of age worldwide is type 1 diabetes. The incidence of type 1 is increasing, and the largest increase is noted, unfortunately, in young children aged between 0 to 4 years. And it's usually, it's diagnosed at all ages. Approximately 1/4 of people with type 1 diabetes were diagnosed as adults. The pregnant patients with type 1 diabetes should check their blood glucose levels 6-7 times daily, before each meal and either 1 or 2 hours after meal. So look, premeal glucose levels should be less than 100 milligram per deciliter. 1 hour postprandial after meal should be less than 140. 2 hour postprandial should be less than 120 milligram deciliters. And blood glucose should never be below 60 milligram deciliter, because it's risk of hypoglycemia. What includes the prenatal care in patients with type 1 diabetes? There are additional measures to routine prenatal care. At first visit, hemoglobin A1C, electrocardiography, 24, urine for protein and creatinine clearance, 24-hour, ophthalmology exam to rule out retinopathy, the foot exam to rule out the unhealed wound. At the second and third trimester, initiate antenatal testing at 28-week. Noster test plus amniotic fluid index or biophysical profile. The monthly evaluation of growth after 24 weeks should be done, and delivery is recommended at 38 weeks. That was about type 1 diabetes. Now let's talk about the type 2 diabetes. Being overweight or obese is the greatest risk factor for type 2 diabetes. And look, according to the WHO, the prevalence of type 2 diabetes worldwide has become a global health epidemic. And programming for early onset type 2 diabetes is believed to happen in utero. it happens in utero. Remember, we mentioned this in utero programming, that non-communicable diseases such as diabetes, hypertension, cardiac pathology is programmed in utero. Type 2 diabetes and gestational diabetes are believed to be the same disease. They just manifest at the different times of life. It is metabolic disease which is characterized by hyperglycemia, insulin resistance, and relative insulin deficiency. Outside of pregnancy, 90% of patients with diabetes mellitus have particular type 2 diabetes. During pregnancy, uncontrolled type 2 diabetes is associated with an increased risk of fetal anomalies, fetal macrosomia, and fetal death. Because the prevalence of type 2 diabetes during the childbearing years has increased, many women may go undiagnosed prior to pregnancy. And women with type 2 diabetes during pregnancy found an 11-fold increased risk of congenital anomalies and 2-fold increased risk of stillbirth in comparison to the general population. Let's make review of the pathophysiology of insulin resistance. Look, normally glucose crosses the placenta by facilitated diffusion, and glucose transfer also requires a concentration gradient, and normally on average fetal blood glucose is about 15 mg/dL less than maternal blood glucose. That's why glucose can easily transfer from mother to the fetus. Insulin and large protein hormones, they cannot cross the placenta, and insulin has limited, if any, role in placental uptake of glucose. Insulin resistance exists when the action of insulin is less than expected in terms of glucose uptake into cells and suppression of gluconeogenesis by the liver. Normally, the pancreas is able to adapt to changes in insulin action as well as the amount of hyperglycemia. That's why not in all patients this gestational diabetes formates. In type 2 diabetes, patients are unable to secrete enough insulin to overcome insulin resistance and to compensate for hyperglycemia. And progressive deterioration of insulin secretion is seen in most patients with type 2 diabetes. And the most significant goal of treatment is preservation of beta cell function. This disease is considered a polygenic multifactorial disorder resulting from the interaction of multiple genes and environmental factors. Look, if one parent has type 2 diabetes, the lifetime risk to the offspring is 40%. That number increases to 70% if both parents have the type 2 diabetes. In monozygotic twins, between 35 and 58% are concordant for type 2 diabetes. What do we need for diagnosis of type 2 diabetes? The hemoglobin A1C is greater or equal 6.5%, or fasting plasma glucose is more than 126 milligram per deciliter, or a 2-hour value is greater or equal 200 milligram per deciliter after a 75-gram oral glucose challenge test, or a random plasma glucose is greater or equal 200 milligram per deciliter in patients with symptoms, who express symptoms. High-risk women meeting these criteria at the first prenatal visit can be given a diagnosis of overt diabetes diagnosed during pregnancy. At the same time, there is a group of patients who have a level of glucose intolerance that does not meet the criteria for the diagnosis of type 2 diabetes yet, and they are too high to be considered normal. These patients are described as having impaired fasting glucose or impaired glucose tolerance. Can you feel difference, right? What means impaired fasting glucose? That means that the fasting levels of glucose are between 100 and 125 milligram per deciliter. So it's upper level of reference range. Impaired glucose tolerance means when the 2-hour value is between 140 199 milligram per deciliter after a 75 gram oral glucose load, and when the glycohemoglobin between 5.7 and 6.4. These patients are in group of pre-diabetic patients. What to do? What includes the management in pregnancy? First of all, evaluation of end organ status and a review of all medications should be conducted at the first prenatal visit. Evaluation of end organ status should include hemoglobin A1C to assess glycemic control over the last 3 months and during period of organogenesis, which includes first 8 weeks. Electrocardiography to evaluate the heart. A 24-hour urine collection to evaluate the amount of protein spillage and the creatinine clearance. An eye exam to rule out retinopathy, a foot exam to rule out non-healing wounds. The review of medications at the first visit to identify medications which should be discontinued and to identify patients who may need counseling regarding medications taken during the first trimester is important. Accurate dating is critical in diabetes. A dating sonogram should be ordered preferably by the first trimester. An anatomy sonogram, including a complete fetal electrocardiography at 18-22 weeks to rule out congenital anomalies, and growth scans should be obtained monthly after 24 weeks. The major goal of treatment of type 2 diabetes is to prevent complication of the disease. That was about the type 2 diabetes. Now let's talk about gestational diabetes mellitus. What are the risk factors? 2 or more are considered high risk for gestational diabetes. So these signs, these conditions, I will tell you now. If you have 2 or more, you can tell that this patient has high risk for formation of gestational diabetes mellitus. The first one is advanced maternal age. Obesity, gestational diabetes mellitus in previous pregnancy, previous macrosomic infant, previous unexplained fetal death, previous polyhydramnios, polycystic ovarian syndrome, metabolic syndrome, and first-degree relative who has type 2 diabetes. What includes screening, diagnosis, and management for gestational diabetes. The gestational diabetes is, again, I will give you definition that it is intolerance with onset or first recognition during pregnancy. But at the same time, during pregnancy, patients may have undiagnosed type 2 or, of course, rarely type 1 diabetes. They would still fall under the designation of gestational diabetes. So, this is problematic because the complications for both the mother and the fetus differ between the gestational diabetes mellitus and pre-existing diabetes. So, to make diagnosis, fasting plasma glucose is greater than 126 mg per deciliter, or a random blood glucose greater than 200 mg per deciliter is diagnostic of diabetes, and no glucose challenge is required. So you can make the diagnosis without any tests. To diagnose a birth diabetes in pregnancy, one or more of the following criteria must be met. The first is fasting plasma glucose more or equal 126 mg per deciliter, 2-hour plasma glucose greater or equal 200 after 75 gram glucose load, and a random plasma glucose greater or equal 200 mg deciliter in presence of symptoms of diabetes. So there is a question: who, how, and when to screen for gestational diabetes mellitus. Due to the possible complications of undiagnosed gestational diabetes, universal screening is recommended. The current recommendation is two-step testing. When to screen for diabetes mellitus? Screening is traditionally done between 24 to 28 weeks. Because insulin resistance increases during the second trimester due to placental hormones we talked about and other physiological adaptations of pregnancy. So, the highest risk of formation for gestational diabetes mellitus is at the second trimester. Patients with a previous history of gestational diabetes, a body mass index greater than 30, and known impaired glucose tolerance should be screened at the first prenatal visit. So, in these patients, we should not wait until 24 weeks, but make these tests at the first prenatal visit. The test should be repeated again at 24-28 weeks if was initially negative. Repeat 3-hour test should be considered for ultrasound proven fetal growth more than 85%. As we said before, the two-step screening system is accepted now and recommended after 24 weeks. 50 gram glucose is given, and 1 hour glucose challenge test is first step. The next is 100 gram 3-hour oral glucose tolerance test. So, do you feel difference that the first one was glucose challenge test and the second one is glucose tolerance test? It is for patients with an abnormal glucose challenge test. So, If the glucose challenge test shows normal result, there is no need for the second one. But if it's abnormal, the next step should be done. The recommendation applies to asymptomatic women with no previous diagnosis of type 1 or type 2 diabetes mellitus. Once again, the screening step 1 identifies women who may have gestational diabetes and should be given the diagnostic 3-hour test. After 50 gram oral glucose load, the patient is tested, and technically it should be done after 3-5 days of a high carbohydrate diet. By the way, the patient does not have to be fasting. Suggested cutoffs range from 130 to 140 milligram per deciliter. A cutoff of 130 or 135 milligram per deciliter identifies more patients and should be used in populations with a high rate of diabetes. Patients who meet or exceed the cutoff for step 1 then go to step 2. What to do? If screened positive following step 1, a diagnostic test, the 100 gram 3-hour oral glucose tolerance test is recommended. What are the values? Once again, fasting should be greater. If the fasting is greater than 105 milligram deciliter, 1 hour is greater than 190, 2 hour 161, 65, and 3 hour 145 milligram per deciliter. These values are recommended. Okay, what is the management? What to do in these cases of the gestational diabetes? On the first place should be diet, and the goal of dietary therapy is to avoid single large meals and foods with a large percentage of simple carbohydrate. So the frequent meals are recommended with the complex carbohydrates. Insulin. The goal of insulin therapy during pregnancy is to achieve glucose profiles similar to those of non-diabetic pregnant women. In gestational diabetes mellitus, early intervention with insulin or an oral diabetic agent is key to achieving a good outcome when the diet therapy fails to provide adequate glycemic control. Glyburide and metformin, the diabetic therapy with the oral agents has been gaining in popularity. Prenatal obstetric management includes various fetal biophysical tests. They can ensure that the fetus is well oxygenated and include fetal heart rate testing, fetal movement assessment, ultrasonographic biophysical scoring, and fetal umbilical Doppler ultrasonographic studies. What is management of the neonate, which is born from mother with gestational diabetes? The current recommendations for infants of diabetic mothers include employment of frequent blood glucose checks, because the risk of hypoglycemia, and early oral feeding, ideally from the breast, of course, if it's possible. If not, infusions of intravenous glucose is efficient. Okay, now let's see what are the risks to mother with the gestational diabetes. Of course, it's increased risk of cesarean section. The preeclampsia, which is hypertensive disorder of pregnancy, and the risk is between 2-4-fold, especially with the coexisting microalbuminuria or frank nephropathy. The next risk is polyhydramnios and preterm birth, postpartum hemorrhage, temporary worsening of renal function, don't forget about small vessels, progression of retinopathy, increased incidence of infection, severe hyperglycemia and hypoglycemia. What risks might be in future? Recurrent gestational diabetes pregnancies and risk of developing type 2 diabetes. In 5-10 years, the risk is 50%. Okay, I've already mentioned complications in infants of mothers with diabetes. So let's talk about them. The first one is intrauterine device. This might include spontaneous abortions or stillbirth. Stillbirth accounts 10-30%. And congenital malformations, neural tube defect, cardiac defects, caudal regression, as you can see on this picture, despite they are rare. Macrosomia, visceromegaly. Visceromegaly is due to cardiac enlargement and hepatic enlargement. The next complication is respiratory distress syndrome, asphyxia, and birth injury. Birth injury happens mostly because of shoulder dystocia, and Erb's palsy is common, diaphragmatic paralysis, and partial paralysis. I have to mention the metabolic complications. Hypoglycemia, because high insulin production in immediate neonatal period due to recent fetal hyperglycemia. Mothers should be encouraged to breastfeed as soon as possible, and at the same time we have to monitor infants' blood glucose. Formula fed or glucose infusion is necessary. Hypocalcemia, magnesium deficiency, leads to apneic episodes and fits, convulsions. Polycythemia leads to hyperbilirubinemia and, as a result, neonatal jaundice, and partial exchange transfusion may be needed. What includes obstetrical management? Nuchal translucency scan. It is usually done at about between 11 and 13 weeks of pregnancy. Detailed ultrasound for fetal anomalies, which is done between 18 to 22 weeks. Fetal echocardiography at the same time. Serial growth scan, which is started from 24 weeks. Monitor fetal well-being, Doppler ultrasound or cardiotachography. What is the aim of this management? We have to continue pregnancy until 38-40 weeks, and the aim is vaginal delivery. The cesarean section should be preserved for cases of macrosomia, preeclampsia, and failed induction of labor, and usually cesarean section accounts about 50%. What to do in preterm labor and polyhydramnios. Actually, it's really difficult to manage these conditions. Why it happens? Look, the tocolytics which we use in preterm labors, they are diabetogenic. What type of tocolytics we use? Ritonavir, salbutamol, ginepral, partusistin, they all are diabetogenic. Intramuscular steroids for fetal lung maturation, the glucocorticoids we use, they destabilize diabetic control. IV insulin glucose infusion should be done if required to ensure normal glycemia. On this table, I try to show you the glycemic targets in pregnancy. Actually, I have already talked about that, just the table for your information. The intrapartum management includes the induced or spontaneous labor with a sliding scale of insulin to maintain normal glycemia. The maternal blood glucose should be tested hourly. Continuous fetal monitoring is advised, and fetal scalp blood sampling if the cardiotocography was abnormal. The pharmacologic therapy includes insulin, and it requires frequent titration to match changing requirements. Of course, during labor process, the requirements for insulin change. The next one are sulfonylureas. They may be inferior to insulin and metformin because it increases risk of neonatal hypoglycemia and macrosomia. Metformin, it's maybe preferable to insulin for maternal health if can control hyperglycemia. But at the same time, it may increase risk of prematurity, and it lowers hypoglycemia and weight gain. The long-term outcomes in offspring not known yet. How to plan the delivery. The timing of delivery for patients with gestational diabetes mellitus or pre-existing diabetes mellitus is guided by the risk of intrauterine fetal demise and macrosomia versus the risk of neonatal complications due to prematurity. So here we have to decide timing delivery or premature delivery. Patients with fasting blood glucose levels less than 95 mg per deciliter and postprandial blood glucose levels less than 140 mg per deciliter 1 hour after meals or less than 120 mg per deciliter 2 hours after meals are usually considered well controlled, and we can wait until 39 weeks of gestation. Women with poorly controlled glycemic levels can be offered delivery in the late preterm or early term period, which means that between 36, 37, 38 weeks of pregnancy. Cesarean delivery should be reserved for cases with the macrosomia, which is considered when the estimated fetal weight is more than 4.5 kilograms. Okay, what to do in postpartum period? In postpartum period, the follow-up should be done in patients with gestational diabetes mellitus. An oral glucose tolerance test is recommended at the 6 to 12-week postpartum period. Because the GDM is associated with increased maternal risk for type 2 diabetes. We should test women with GDM every 1 to 3 years if her 6 to 12-week oral glucose tolerance test is normal. The frequency of screening is based on the presence of risk factors, family history, or pre-pregnancy body mass index is increased, or need for insulin or oral anti-diabetic medications during pregnancy. Ongoing screening may be done with any glycemic test, glucose hemoglobin, fasting plasma glucose, or oral glucose tolerance test using non-pregnancy cut points. Of course, she is not pregnant so far. Metformin and intensive lifestyle change prevent or delay progressive to type 2 diabetes. And of course, I have to mention the diet, the frequent meals with complex carbohydrates. Okay, that was about the diabetes mellitus, and now I want to talk about the thyroid pathology. Thyroid disease is second only to diabetes mellitus as the most common endocrinopathy that occurs in women